All right. So again, thank you, and I'll give you a little overview. It's what's I think right now driving the field and what we're seeing in that space. So here are my disclosures. Really important for me. I think full spectrum of surgery. If you can't do an open laminectomy, if you can't put in pedicle screw with visualization and X-rays and freehand them in case you need to. If you can't use navigation for big cases. Every surgeon should be able to do that, and it's part of my armamentarium. Otherwise, I couldn't fix all the trauma at Harborview that I do. So it's really important to see that in context. Context is everything, especially in social media. So the outlays. So I would like to sort of hone down on the intraoperative technologies that I think, and some of them obviously there is going to be some repetition there that facilitate the surgical progression. But I also want to go back to why I would be using these technologies at all, right? I think we kind of. I think by thinking about the reason why we use things, go back to the fundamentals, we can invent new things. And especially, fantastic talk before, but I think the robot is going to bring new stuff to the table that we can't do with navigation, and we can keep that for lunch. But there's a lot of cool stuff coming down the pipeline. And then familiarize yourself with expandable cages, especially in the endoscopic realm. That's really important, that new technology that comes out, 3D expandable cages are coming around the corner, and they're going to change the field entirely. And then potential, I want to show you guys how endoscopic spine surgery and MIS has totally changed my clinic. I mean, you can't compare it what it looked like 5 years ago. And that's big time savings. Surgeons don't only work in the OR. We work in between cases and in the clinic, and nobody ever really talks about that too much. So here are the parts of the talk. So this is, something that, I come and I see every day. Patrick is nodding his head back there, my fellow, is like, what do we do? So you have a patient on the table. How do you get to your problem, right? How do you get to the pathology? And in open surgery, it's kind of easy. And I'm sure everybody, remembers their attendings when they were training. They were slapping the patient on the back, and they were like, here's L3, L4 open there. No X-ray, nothing. Then afterwards, we got an X-ray to kind of see the level, like you see here. Then you open the skin, you put in your finger, you palpate. And then you hopefully see many, many different landmarks, right? And that's where navigation and robotic comes in. You don't have to do that anymore. Endoscopic surgery is much more precise, right? You don't have like segments. You have like one little target area. So it's like one little bony area that you want to reach. You can't put your finger in there unless you have really slim fingers. And we can check that too, but typically you can't because the incisions are so small. So you use a little trocar. To palpate that area, and then you have to visualize this thing, and there's no redundancy. It's one spot. You have to find it. If you're off, you are off. Right, Patrick? Yeah. These are the and that's the learning curve, is you have to get the ideal trajectory. If you're off, you end up with 2 incisions. When did that happen last time? You have to be so precise. And it helps you with open surgery too. I mean, I very much appreciate your talk. It's like, if you're good with robotics, you're going to be good with other things too. It's like you learn a skill and it spreads out to other fields too. Deviation of the trajectory. If you tire, it's not that we do one case and then go. I mean, like, there's one case and then 3 traumas are waiting in the ER, right? It's tiring, you get a call. And with the endoscopic stuff, is you tire, the endoscope sinks in, you change trajectory, don't see anything, you're off. Difficulties to create that workspace. It's a very different skill to do that. And inability to identify the target areas. So these are the things where all the fellows and the residents, when we train them, is like each step is like back and forward, back and forward. So that's kind of the learning curve. And that's where navigation comes in, right? Because navigation, here's like an EM navigation for endoscopic stuff, is, you register the patient, and then you bring in the needle, and it tells you exactly, this is kind of like a little bit more old-fashioned AP and lateral fluoroscopic guidance, but you can see how the needle goes in there. And as a novice, to bring in the needle into the field, you probably have like 10 to 20 X-ray shots to get there, and here you really have none. And radiation exposure, I couldn't agree more, is key. I mean, we all kind of bombard ourselves with radiation. You would not get a single administrator into your OR with 2 lead shields and 3 lead heads and lead goggles. They would not stand in your room for a minute, and we are right next to the amplifier, right? Have you ever seen an administrator in an OR when you get an X-ray? I've never seen that, right? But we are in the beam, because because we want to help people. It's important to take care of ourselves. And so that topic is very important, and we put it in a book into two that I wrote a couple of years ago. And that's where it really shines, is the post-endoscopic foraminotomies, because it's hard to get those AP X-rays to get in there, and you can sort of really struggle there. Transforaminal interbody fusions, MIS, so endoscopic, and the transforaminal approaches to the spine. Here's a little paper on that where they combined navigation with endoscopy. Just looked at 23 patients, 20 lumbar cases, 3 cervical cases, and they conclude that it assists, it's feasible, and it helps with workflow. And so now I just want to show you, I think the BMI that I heard right now before was 40, so I want to up that here a little bit. 63-year-old morbidly obese female. I think there's something beyond that too. There's some super morbidly obese or something. I think there's a word for that too. But anyhow, nicest lady in the world. Has arthritis, fibromyalgia, IBS. So a couple of hits against her in terms of expected outcome. But the problem is I couldn't send her home and say lose some weight, right? Because she has developed perineal numbness, lower extremity weakness and pain. You see an ODI score was 60, leg was 9, pain, back pain was 7. On exam, she was still intact, but again, those episodes of perineal numbness. And here is the L4-5 level. You see this gigantic central disc there? High-level stenosis. So this is a liability. This is not a patient you can be like, hey, why don't you lose weight and I'll see you again next year, That's just not possible, right? At least not where I am. I can't send patients anywhere else. I could send them here, but that doesn't work. I'll think about that. So there's an intraoperative picture. So we had to both decompress her and fuse her. So here are the hubs of the screws, the sleeves, so they barely make it out of the skin. We use navigation because we're not as fancy. And then back here also at the hub is a decompression. So that's the endoscopic port for the decompression. So here it could go in transforaminally on the side, and these are the ports for the screws. And here is the navigation reference array. This is kind of what it looks like. So you go in transforaminally. I'm not going to bore you guys too much. Here is the thecal sac coming in. Left side is rostral, caudal. And now we start to work on this disc. We drill right in front of the area, so the neural elements. And that's, again, as Daniel pointed out, you have to have a lot of patience. And then you start moving the stuff and freeing up the neural elements ventral to that. Those central discs are very challenging, and I've done a lot of them open, before we use that. Use the down angle correct, and then at some point it's like CSF, and you're like, It's kind of always like that, because you always get the contralateral side with the down angle correct, and then CSF comes. And maybe if you're unlucky, some nerve roots. So this is what it looks like before, a game changer. The particular transforaminal approach is, you have to learn it, but it's a game changer for these patients. And this is what the x-rays look like. And again, in my talks, I swore to myself, there's not going to be any more of the patient to dwell. I can't hear it anymore. So these are the x-rays. So we got, I think like roughly 10 degrees of additional lordosis, used an expandable cage. And up there is, she's 3 months out right now. You see the leg pain resolved. The first couple bars of the first stays. ODI was worse. Patient, as an investment, right? After surgery, patients suffer. They have more back pain. She's off opioid medication. So down there, the last bar graph is opioids. EQ5 is getting better, and leg pain is resolved. And the back pain is still, she's still, I think, like a 4 to 5 out of 10.
That cage you put in endoscopy?
Yeah. Here we go. And so these are the outlines. I think I'm going to not go through that because I think your talk was much, much better about this. So, but again, there's a learning curve and capital cost. There's some need for planning. We also have dabbled a little bit with robotics in endoscopy. It provides robotic targeting, endoscopic visualization. One of my fellows was super interested in Dr. Hassan. He is doing a great job with that. So we did a case there where we had the robot, you can see that, help us with the trajectory, right? I mean, endoscope is very, very small, as I told you, and it really helps you to kind of get there and to get the targeting right, get everything on a trajectory. And that works really well. So those technologies marry quite nicely. And then here's an intraoperative view. The nice thing about the endoscope, you can visualize the end plates, so it's actually much more visualized than open surgery, just saying. And here's a postoperative X-ray of this case, some stab wound incisions. Couple of words about cages, and I think this is going to be a much more interesting talk in a year or two from right now. I've used expandable cages really for the last 10 years. And the reason for that is I think it prevents irritation of the exiting nerve root upon introduction. It can be expanded in situ, and we have all seen the non-expandable cages. They're floating down there somewhere and have barely bone contact. So I think it's really valuable technology there. You can backfill them. Disadvantage is the price, and sometimes it can be rather complicated to bring it into the place. Here's different models, different cages, and you see that the names are removed, so you can all only imagine what the names of these devices are. But there's some devices that can be, filled with bone graft and sort of have three-dimensional expansion. There are some cages that have flares and have a similar name, but I don't want to make any hawkish comments. And so you can see that there's different technologies here. One other thing that I think is going to really sort of impact, the way we do surgeries is osteobiology, right? In the end of the day, again, go back to the roots, right? Why do we do instrumentation? Well, it's an internal brace, right? And the better the osteobiologics are, the less bracing we need, right? And so autograft, allograft, DBX, BMP, and newer technologies that are coming down the pipeline. So I think I would keep a close eye on those technologies, because the better these materials are, the less important the brace is. All right, and so now that brings us to the last part before lunch. Is lunch served already?
Yeah, it's ready.
The lunch is served, so, okay. So we got time? Okay, perfect, good. So, this is honestly, the technology is interesting, and I think I think I learned so much listening to these talks. I think again every one of these talks I pick up like 2-3 new things. But one thing that we never really don't talk that much about it. What is the impact of all these procedures on us? Does it mean that we can now, for the same money, add another 2-3 cases a day, right? At the end of the day, it kind of comes down to that. But what we have seen is like procedures are becoming more standardized, right? So for example, in the endoscopy a couple of years ago, we put this list together. So those are all procedures that can be done with an endoscope. And if I do this procedure, or Mark Mahan does it in Utah, or Telfian does it at Brown University, or Brooks does it in Wisconsin, it's done very, very, very similar. It's very, very similar. And there's the same name, same procedure, same goals and everything. So they're almost completely standardized now. And I think it's important to standardize things for teaching, for sharing knowledge, and for comparing outcomes. So this is like from AO slides that I made once, a teaching curriculum for them, and from a book that we published. So every procedure is standardized, and we really need that in order to speak the same language. The outpatient procedures, spine surgery has changed. We're almost kind of becoming more and more like dentists, because a lot of these procedures can be done, patients go home. Here, just an example, a lumbar discectomy, again, a discectomy, I think, I'm not going to have the discussion. If you use a tube open, patients can go home the same day. That's not the halo procedure we're talking about. Lumbar laminectomy, I think more of an issue here a little bit. Patients go home the same day, typically, unless they have medical morbidities. Lumbar T-lifts, same days, next morning, versus 5 days open T-lifts. Favorable complication rates, right? We just published a paper a couple of years ago where we looked at 500 patients done endoscopically at these different places. At this time, we were still called ESSG. Now we call ourselves ESRG, a big change. And complication rate was 4.7%. Now, complications happen. If you don't have complications, you probably don't operate. And again, they happen all the time, as we discussed right now, right? And they are tough on all of us. But the rate is luckily pretty fortunate. That's pretty favorable. Here's a paper I think that is interesting. It's in submission right now. We looked at the last 1,261 endoscopic cases, compared them with 5,936 patients that were propensity scored from the NESCRIC database. If you look here, very, very similar. Obviously, the propensities matched, so very similar cohort of patients. But what the difference is that we found in this large cohort of almost 7,000 patients is, while surgical wound infections are rare with non-instrumented cases, like 1% roughly, so very rare, they are even more rare if you flush gallons of water through your wound during the surgery. That takes a long time, right? And so the rate of infections is 16-fold lower, 16 times, not percent, times. Personally, I've never seen an infection with these surgeries, but we had, in the whole cohort, there was one infection, one superficial infection. And that's a big deal. We always seen patients after discectomy that develop osteomyelitis, and then the robot comes in, right? The really cool stuff, but at that point, you're not interested in the robot anymore, so. And so what we found is that when we are looking at these patients, only 50% of these patients ever come back to us after these surgeries. They're like, hey, thank you, doctor. See you, done. And that's just very hard, because, how do you, as a surgeon, learn if you don't know what's happening to your patient? I find it, when I don't have time to see my patients, my energy level disappears. I don't know how you guys feel it, but if I don't see the result of my work, you might as well do whatever, right? It's just, if you don't see the result of all that hard work, you burn out. The energy levels decrease. And 50% of these patients never show up again. I only see the patients that don't do well, right? And so what we had, like before COVID, BC, we used these, paper forms and sent them to the patients. Most of them didn't send it back. Now we switched over to telemedicine visit. They don't even have paper stuff anymore. So even fewer people filled it out. And what we saw, in addition to that during COVID, I'm sure you all have seen it, people take off. They don't, they take other jobs, and maintaining people that sort of can do that work for you to follow up your patients is hard to get. And our outcome, follow-up became really, really poor. And so that's when we started to look into a more sort of advanced technology to do that. So we saw that there's a very nice paper by Dr. Park. They looked at surgical patients. More than 70% of our patients use smartphones. I think it's really almost 100% nowadays. And they're interested in talking to the surgeons and communicating with us and sort of getting some help via that technology. And that's what we have embraced here now, is like, for the patients, it's nice for them to see the recovery. They want to get access to the surgeon. They're picking as we discussed before, they're not going to Google the hospital that you work at, they're going to Google you. And that's important. So they want to kind of have, access to you in a way, because they were looking for you and not for somebody else. They don't like to come to the hospital anymore for follow-up for the wound check, right? The wound they can barely see. And resources, they want to know how they can recover better. And the challenges we saw is like very quickly, seamlessly sign them up and create an interface. That the oldest patient in the app right now is 88 years, and she's doing fantastic. She's probably the top performer in the app in terms of filling everything out. And this is what we have designed. It's a university project, so there's no commercial interest. They still covered it up, but whatever. And so you can see how we sign up these patients. So again, everything is standardized. So we have all the procedures in there that are standardized. So it's very simple to kind of put it together. So when we have it at 6 universities now, so if Dr. Telfian at Brown does a procedure, he does them exactly the same way as me, so we can put them in the same pot and compare our patients and our outcomes. So we ask them the first couple of days of the surgery, 3 months, 6 months, 12 months, 24 months. The follow-ups are virtual, so nobody comes back to the clinic anymore. There's a small questionnaire at the end that is like asks mainly about systemic infections. They send a picture of their wound at 2 weeks, and that's it. At 3 months, it's just like, would you have the surgery done again? Any issues? And that's it. So we have enrolled 210 patients right now. So this is we're talking about 400 clinic visits. And this is what it kind of looks like. The PROM is an example patient right now. So this was a stenosis patient, as you can see here, ODI, VAS for the leg pain, EQ5 we collected for, and then here's the 2-week follow-up on the right side. So it asks about fevers, night sweats, wound redness, wound tenderness. And then we're also looking at their stepping, so which is actually very interesting. When I see a patient now, I talk to them, I communicate them, I always look at the stepping data, because you wouldn't believe that some patients that couch potatoes, they don't walk at all, and other people are active, even after surgery. And it's nice to see, if a patient really is like, oh, I'm hurting so much, you're like, well, you walk 10,000 steps every day. It's like, it's like, I would be hurting. But it's you get a much better, picture of these patients. And so we did a study here at UW and included, we had a compliance rate of 91%. So of all patients that we asked if they want to do a virtual follow-up, 91% of all patients said, yep, sign me up, thank you so much, that sounds like a great idea. At least 85% had one PROM. So of that, so just uploading the app to them, 85% gave it to us compared to 50% before. 3 months follow-up was available at 74%. And 100% were compliant with the follow-up. So all the patients actually did the virtual follow-ups. There was no, they might have given us the numbers, but all of them did the virtual follow-up. And that was the difference. So that's kind of a scaling grade for mobile healthcare applications. So you can see ease of satisfaction. The bar lines, the maximum is up here.
Does this data go back to the medical chart at all? Is there any communication between the two?
So right now is I just put in screenshots, okay. But right now I wrote a note back there quickly, and I just take a screenshot and put it up. There is a plan to put it back to kind of have a backdoor for that, especially the PROMs. So we're working on that. The problem is this is so nimble that if I make a change, it's implemented next week. Try that with Epic. You'll probably be 2-3 generations after you. It'll be Drazen the Third is going to be, my dad told them to change that. Look, it's finally done. And so actually patients really loved it. So it's like you can see that the score was of the total mobile health app score was 82% of a maximum of 100%, and that's kind of under the development. But those were the the priorities of the patient in the survey. They want to talk to us. They want physical therapy instructions. And they want to review the images. And that was actually something that I never thought about. So now we can just upload a picture quickly, and the patient sees it at home immediately. And it goes both ways, and just it's just seamless. And here's again, we're almost at lunch, 2 more slides. So here we're breaking up the different things, so easy to use. The interface they liked, how they, for the most part, were satisfied with it. They think it helps them for monitoring their progress, and all over were very positive. Now, the interesting thing is this was really in us developing the app and sort of having a lot of bugs and other stuff. So this is not by far not a commercial product here right now. And despite that, patients were super positive. So we have spread that out now to endoscopic surgeons in the country. So all these surgeons do at least 150 endoscopic cases a year. We have this out there is mainly right now as a study group. So now instead of ESSG, it's ESRG, so Endoscopic Research Group. And what we're doing there is basically think about it as a quality outcome tool. So within a couple of seconds, we can see what is University of Michigan, how much opioids do they use after these procedures? How much do we use? And it's within all that data can be analyzed and for the betterment of our patients. So for example, right now we just compared awake versus asleep transforaminal surgeries. And so we can immediately pinpoint that and learn from each other. That has been really super, super exciting. We can look at benchmarks, and honestly, I want to have these talks at some point where the people that are doing something really great and can have the data for it to teach other people, right? And I think we're getting there. And quality improvements, how to make things better. And that brings us to the conclusions. So I think intraoperative guidance techniques, navigations, and robotics facilitate the progression and help us with making these procedures safer, more efficient. The 3D expandable interbody cages hold a promise to really bring endoscopic surgery to the forefront of interbody fusions. Physician-driven apps help to, with follow-up, facilitate the communication, and really of all the stuff that we talked about today, that really has saved the most time for me, because patients that do well, we just, I know that they're doing well, they know that I know about it, and I don't have to have them come in, park, see them, all those other things that we have to do. And that brings us to the last slide. So thank you so much for listening, and I'm open to answer any questions. Thank you.
Christoph, that's a great lecture. And, I want to give a little historical perspective and actually acknowledge you for bringing this together. Because way back when, there are some names of people like Parvez Kamben. I mean, he's basically the father of endoscopic spine surgery back. I met him in the early 90s, and he was a visionary. We know what Kamben's triangle is, right? He described it because that's where you do the procedure, or the beginning of the procedure. And then there were some lightning rod guys around like Tony Young, who was a big zealot of endoscopic surgery. And, it needs to have image guidance technologies or some type of guidance that the everyday surgeon can use it.
Yep, absolutely.
Okay, you're an incredibly talented guy. You have pushed this thing forward to the point that, it needs to be. In fact, somebody asked me, some of the old guys, they said, Johnson, why don't you take this endoscopy thing and merge it with image guidance? And I said, yeah, well, I only have so many days, hours in the day. But this is what's needed to bring this to everyday working capability. And it's in progress.
And the really cool thing about this whole thing is, like, we always are like navigation versus robotics, right? But what does robotics give us additionally to that? And the cool thing is, using these really small approach corridors, robotics is going to knock it out of the park. And the reason for that is because, this unnamed cage in the right lower hand that was very hawkish, what they have invented, the concept of bringing in stuff serially, right? You bring in one piece and then you bring in the other. It's almost like the Luna docking, like you just bring in different things in the same corridor and then you assemble it inside, right? That's really hard to do with navigation. Right, to assemble stuff serially inside, it's almost impossible with navigation. But guess what? Robotics, boom, no problem, right? And so I think that's that serial application of stuff. I just, if you take on one thing, because you guys are almost much smarter than me, that is the cool thing about robotics, right? You can have the same trajectory. You have your highway in there. You can go in there and assemble stuff. You couldn't do that with navigation. And I think we're going to see stuff coming out of the pipeline from different companies that are going to use that concept. And then navigation will look very antique very quickly, like us, because we don't have robotic stuff. So,
okay, thank you so much.
Great talk.
Thank you.
Great talk. Thanks.
All right.